Today we're going to be talking about oculopalatal myoclonus, and it's called that because the eye is going up and down vertically, and the palate is also moving up and down, and it's myoclonus, and it looks like this. So vertically the eye will be going up and down. So it's not like downbeat, which has a fast phase down, or upbeat, which has a fast phase up in nystagmus. It is a pendular vertical oscillation. It's often very small in its amplitude. So if we see a vertical pendular oscillation of the eyes, ocular, and we want to have them open their mouth and look at the palate, and so the dangly thing in the roof of your mouth, the uvula, will be going up and down like this. So if the eyes are going up and down and the palate is going up and down, that is oculopalatal myoclonus. This oculopalatal myoclonus occurs because there's a lesion in the brainstem inside of the Guillain-Molare triangle. The Guillain-Molare triangle is composed of the dentate nucleus in the cerebellum, the inferior olive in the medulla, and the red nucleus. So if you have a lesion involving the red nucleus, the inferior olive, or the dentate in the cerebellum, any lesion inside of that triangle, called the Guillain-Molare triangle, will disinhibit the connections to the olive. And when that happens, the lower cranial nerve inferior olivary fibers in the medulla will cause the palate to move because it's been disinhibited. So when you inhibit the inhibitory fiber, it unleashes the palate movement from the lower cranial nerve involved in the medulla, which is the inferior olive. The ocular part occurs obviously from the upper brainstem portion, the red nucleus, midbrain, and cerebellar control fibers in the dentate nucleus, cerebellum. The interesting thing about this is normally there's some lesion that starts off rostrally, like in the pons, that actually disconnects the descending fiber to the olive. So it's a delayed effect. It's delayed. So the patient has a hemorrhage, for example, in the pons, or a stroke in the pons. Then months later, their eye starts to move, the ocular, and then the palate starts to move, because it takes time for the inferior olivary hypertrophy to occur from the disinhibition caused by the initial pontine lesion. The reason it's important is because if you repeat the MRI scan on this patient who has a new finding, ocular palatal myoclonus, the MRI only shows the same lesion is actually smaller. But the key and differentiating radiographic feature that we're going to be looking for is increase in the size of the inferior olive, and that's in the medulla, way far away from the eye movement abnormality. So in summary, in every patient who has a pendular vertical nystagmus, ocular, we have to look at their palate. If we see ocular palatal myoclonus, both the eyes are moving up and down and the palate is moving up and down, then we have to image the patient looking for a lesion in the Guillain-Molare triangle, the dentate nucleus in the cerebellum, the red nucleus, and the inferior olive. Over time, the inhibition of the inhibitory fiber leads to the palatal movement and a radiographic finding of T2 change or increased signal or hypertrophy of the inferior olive in the medulla, and it's a delayed effect after having some rostral lesion, usually a hemorrhage in the pons.